Today, we're honored to feature Dr. Brent Pickett as our speaker for the webinar, and he will share his experience on sports ultrasound. This will be a comprehensive beginner's lecture geared towards medical students and residents. My name is Anish Rana, and I'll be serving as the moderator for today's webinar session. I'm currently one of the AMSSM MSIG officers, serving as the vice president, and a fourth-year medical student at the University of Rochester in upstate New York, applying to PM&R this year. I'm extremely interested in MSK ultrasound, having chaired the Expert Education Student Ultrasound Fest, and with future goals of becoming RMSK certified. After Dr. Pickett has finished his presentation, I will serve as a moderator for the Q&A segment as well. And during the webinar, I would like if you guys can enter your questions into the chat, and during the Q&A, I'll ask each question that was entered into the chat to Dr. Pickett, who will respond to each question. And now it's my pleasure to introduce Dr. Brent Pickett. Dr. Pickett is currently working in Logan, Utah, in the area where he grew up as a primary care sports medicine physician for Intermountain Health, as well as serving as a team physician for Utah State University Athletics. He did his residency in family medicine in South Bend, Indiana, and sports medicine fellowship at Duke University, and he has been in Logan ever since. Dr. Pickett, you now have the floor.
Awesome. Thanks, Anish. Hey, really cool opportunity for me to kind of be able to present a little bit on this. Man, I feel like musculoskeletal ultrasound, I don't want to say it's the wave of the future because I feel like it's here. It's just such a huge part of sports medicine and a huge part of what we do. And when you run into sports docs that aren't as ingrained into the ultrasound as they can be, I think you're just leaving a lot of knowledge and a lot of ability to help patients on the table. So that's why this was kind of an exciting opportunity for me because I tried to attend as many of these as I could as a student and as a resident and certainly as a fellow, and had plenty of my mentors teach me and kind of give time. And so I'm grateful for the opportunity, hopefully, to kind of be part of the village that raises the next generation here, I guess, you know. So um, there we go. I was gonna say it doesn't want to come with me here. I don't have any disclosures. A lot of the stuff I talk about today, you know, there's nothing new under the sun. I took my pictures from a lot of other places and textbooks and websites and things like that. I do have a few of my own from clinic and stuff, but don't have any disclosures to talk about today. So objectives, wanted to talk about ultrasound basics and terminology, discuss kind of basic ultrasound technique, and then review high yield anatomy that you guys are going to kind of see, and stuff that you can get your hands on and start scanning if you have access to an ultrasound as soon as possible, right? So the biggest thing, ultrasound is a language. Those of you that have learned a second language, that speak another language, know that, especially if you learned it, like if you didn't grow up speaking it. I learned Spanish in my late teens and early 20s for my church mission. And it's just, you have to make 1,000 mistakes. You have to jump in, you have to get your feet wet, and you have to make your 1,000 mistakes as quick as you can so that you can get as proficient as you possibly can at it, right? You have to have reps. You have to have reps of what you're looking at. If all you ever do is come in and look at things that you already know are abnormal, you're just leaving a lot of good opportunities on the table, right? You've got to build a mental catalog of the thousands of shoulders and the thousands of knees and the thousands of hips that you've looked at, so that when you see something abnormal, see something you don't quite understand, that you have a good catalog of things that you can pull back from, right? So learning that language and learning what it should look like, what it should look like, and what it shouldn't look like is going to be really important. And then use it or lose it. You know what I mean? It's the same as any other skill. It's only going to be as good and as sharpened as you keep it on a day-to-day basis. And so that's one reason why I incorporate musculoskeletal ultrasound so heavily into my practice, is because it's a great tool. It's a skill that I feel is central and essential to my job as a sports medicine physician. And so that's something that I want to keep at the ready. So these are things I'm just going to touch on, some very basic things. As far as probes go, a lot of you guys probably know this or have had a chance to review this in clinic. The linear probe here on the left is kind of the workhorse for most musculoskeletal conditions that we scan. It's higher frequency, going to give you a higher resolution. And as you start to look at deeper structures, deeper joints, deeper tendons, things like that, it's going to kind of start to lose resolution a little bit. But for the more superficial and higher frequency scans that we do, the majority of which are on today's presentation, it's going to be a linear probe. The curvilinear probe, it says here abdominal ultrasound. Lower frequencies, you can kind of plumb the depths a little bit. There are certain procedures and certain scans that I will preferentially do with a curvilinear probe, like hip injections and things like that. But for the most part, its diagnostic value is relatively limited just because it's shorter or because it's lower frequency. And then this phased array probe, um, higher or lower frequency, but can kind of shoot into tighter spaces. So it can be of some benefit, but really the two big workhorses are going to be either the linear probe or the curvilinear probe in musculoskeletal ultrasound. So a lot of times you'll walk into a room and have multiple probes and you're not really sure which one to use. When in doubt, go for the linear probe. And you're usually not going to be wrong by reaching for that one. Understanding what your transducer is doing, right? And understanding that it's emitting sound waves and how that generates the picture that you are seeing on your screen is going to be important as well. Because you're either gonna, there's multiple things you guys will remember from physics classes in your undergrad, right? Reflection, refraction, dispersion, absorption, divergence, all of these things. Understanding what different materials, what different soft tissues do when the sound wave hits them and how your transducer is going to perceive that is important as you understand what you're looking at, how to describe it, how to use the technical language in order to communicate your findings to other medical professional and other people in the know is going to be important. So certain tissues like bone are going to reflect, whereas fluids of different densities are going to refract the sound waves. Some may just absorb, and some may, depending on the different densities, may cause a divergence and kind of a distortion of your pictures is coming back. So as you learn to speak that language, you kind of learn to understand the probe. And it kind of becomes an extension of you and an extension of your physical exam. So you learn to read those images in the same way that you would another language, right? So descriptive language, a lot of you guys probably already know this one too. We talk about echogenicity as the basic language of how you describe what a structure looks like. You start in the middle with isoechoic and then hyperechoic versus reflective, where like a bone, an intact cortical bone surface is going to be reflective, whereas, a hyperdensity calcium, some heterotopic ossification within a tendon might be hyperechoic. Isoechoic is just kind of a neutral finding, whereas hypoechoic and anechoic in the right context can signify fluid or pathology or whatever it may be. So you're kind of going to describe things in the terms of echogenicity. Um, Before I move on to the next slide, I had a whole slide on knobs and on gain and on everything else. Uh, Excuse me. I ended up deleting that slide because I feel like that's one, get your hands on the machine. You can turn up the gain to basically turn up the brightness. You'll understand the focal zones a lot better once you've got your probe on the patient. And I felt like our time was probably better spent today discussing more of the anatomy. Once you get your probe on and get gel to skin, you're going to be able to understand those focal zones and everything else a lot better than I felt like I could explain them today over a PowerPoint presentation. But as we go through and look at these pictures and look at these different pathologies and positionings today, we're going to try and use these technical descriptions. And as you're looking at these pictures and as you're looking at your own scans, think about what are the sound waves doing? What probe am I using? And is this giving me the best window, et cetera, right? So, talking about shoulder ultrasound, understand the anatomy. I feel like I've become so much better at anatomy since I've started musculoskeletal ultrasound. I did as much as I could in residency as a family medicine resident in Indiana, and then obviously in fellowship at Duke. The thing I really liked about the program was you had a probe in your hand with almost every patient. Every procedure you did was ultrasound guided, and there were a lot of diagnostic scans and an opportunity to really put into practice the functional anatomy that you have to understand when it comes to diagnostic ultrasound. Um, some basics once you get your hand on a probe, don't just scan blindly and kind of throw it on whatever spot they say hurts and start scanning up and down. Understand the anatomy and start with a bony home base, right? So for rotator cuff ultrasound, for shoulder ultrasound, I usually try and start with the greater tuberosity at the insertion of the supraspinatus, which we'll talk about a little bit. So I have a home base. I know where I started and I know where to go every time. You don't just want to dive in the middle of soft tissue and have no idea where you're starting. Make sure you have a bony home base that you can start on with whatever scan you're doing. And then also understanding the context, right? The context of where the patient hurts and how they hurt and everything else. The same thing as an MRI. You know, having an MRI where you
حالا
don't
این
really have
با
anything
این حرف
on
زد
context is going to be a little
زبانه
difficult,
و
right?
به من
So,
گفت که کسی که
making sure
دکتر
that you understand the
دعواتون
context of your scan is going to be important as well. Okay, so um, those of you that have seen rotator cuff ultrasounds, the big thing is, kind of this picture right up here, this modified CRAS position is the best positioning for kind of optimal, easy access ultrasonographically to the supraspinatus. Basically, I just tell the patient, I say, take your hand just like you're going to put it in your back pocket. And you can see in this picture here, that red band is kind of where the supraspinatus comes. And if you try to scan it with the patient in a neutral position, it's going to be really hard to visualize and get your sound waves down into that subacromial space to be able to see the tendon. So basically, when they put themselves in that modified CRAS position, it's going to rock the humeral head anteriorly, and that's going to expose that supraspinatus so that you can visualize it a little bit better without having to try and shoot around the acromion. So you kind of get a good longitudinal axis view of the supraspinatus, like you can see up here in this picture. So you got to think about the windows and think about the context and what am I actually looking at. Just because you put your probe on the top of the shoulder doesn't mean you're seeing the supraspinatus, right? So make sure that you set the patient up the same time so that you can look and see what you're doing. Um, major structures here in this modified CRAS position. The first is going to be the supraspinatus running in long axis and attaching onto our bony home base here at the greater tuberosity, right? So kind of starting up here a little more superficial, you've got the deltoid sitting up over the top of the supraspinatus tendon. That's the first thing your sound waves are going to hit after hitting the skin and the subcutaneous tissue. Um, and then you'll see this subacromial bursa, which just kind of sits as kind of this concentric black line here that sits in between the kind of that hyperechoic, shiny almost appearance of the supraspinatus and then the darker, more fibrillar appearance of the deltoid. So you've got that tendon with the bursa in between and the deltoid, and then the humeral head and the greater tuberosity kind of creating this crow's beak appearance. That's kind of your textbook view of your supraspinatus tendon inserting onto the greater tuberosity. And this is where I'll start almost every shoulder scan that I do, unless I have a compelling reason to start elsewhere. Supraspinatus seems to be the one that's most often affected in patients that you'll see in clinic, and is kind of an easy scan and an easy one to start on with shoulder pathology. So once you start practicing your shoulder scans, this is going to be a big one. I thought I was pretty good at it when I got into fellowship, and we had butterfly scanners that we would use, and we'd go in and our my one of my mentors, Jeff Bytomsky at Duke, would send us in, and we'd scan every rotator cuff. And through most of July and August of my fellowship year, I'd come out and show him the pictures, and he'd look at me wondering what it was I'd actually taken a picture of. So as you get over, or as you get more reps under your belt, you'll figure out ways to kind of get this longitudinal view with the crow's beak and the greater tuberosity and everything lined up so that you have a good picture to be able to show others with regards to what's going on. So here's just kind of a little highlighted layer by layer. If you guys go back and refer to these slides, you can see layer by layer kind of what you should be looking at. And there's a lot more nuanced anatomy when it comes to these pictures when you start getting into certain ligaments within the shoulder and the rotator cuff. But for basics, this is basically what you're looking at. Biceps tendon is usually where I'll go next. I'll usually pull them out of the modified CRAS position and just have them supinate the hand and just put them in their lap. And then you can catch, I'm just going to move that out of the way. There we go. Then you can catch the biceps tendon in short axis sitting in the bicipital groove here. You can see the two little white arrows pointing into that spot. And you can see as you scan up and down, you can scan distally to the junction where the pec major tendon is going to come in and kind of choke off that biceps tendon sheath. And then you can scan superiorly to where you come into the rotator interval, where you'll have the supraspinatus, the biceps tendon, and then the infraspinatus coming from the other side, and even scan up superiorly to where you can follow the long head of the biceps tendon into the shoulder joint itself. But usually home base for this biceps scan after you do the supraspinatus is going to try and find it in the bicipital groove and then try and kind of angle that probe a little superior, kind of, in the cephalad direction, because if you're shooting straight on at that biceps, it can look hypoechoic, and you're not going to be able to see those fibers as well as you'd like. And it may even look like you've got a lot of peritendinous fluid or maybe even a biceps tendon rupture if you don't angle that probe. I mean, it can even just be 10 degrees cephalad to see if you can get kind of this. This is a good picture right here with that hyperechoic appearance of the biceps tendon. Um, there we go. So now looking in long axis to the tendon, you can see that you keep the patient in the same position, but you just position that probe kind of 90 degrees. You're in axis with the tendon, and you can see the tendon here in this middle picture climbing up and then turning the corner around that humeral head, um, so that you can see it as it crosses through that bicipital groove and then dives deep into the shoulder. And then, if we were to continue that scan more proximally, you can use your probe and orient it obliquely, following that tendon up as it kind of runs more obliquely to dive deep into the shoulder. But that's a good spot to find pathology, whether it be a biceps tendinopathy or an intra-articular effusion manifesting kind of into the biceps tendon where it communicates with the inside of the joint there. That's something that you can see there. Um, this subscapularis tendon is usually the next one that I'll go with, and this is one that you can kind of evaluate dynamically. You'll find it just medial to that biceps tendon sitting over the anterior aspect of the humerus. I find that it's still best to keep that hand supinated, and then you can kind of internally and externally rotate the upper extremity that you're scanning dynamically, and you can assess for pathology within that subscapularis tendon, bursitis, tearing, or whatever, and dynamically assess for subcoracoid impingement, which we'll have a video on. It's fairly rare, but it's one that you can dynamically scan for there and rule in or rule out fairly quickly. The thing to keep in mind is, we'll look at some rotator cuff tendon tears later, but this subscapularis can appear a little different, where it may appear to the uneducated eye that it's torn. Excuse me, it'll have several bundles, kind of finger-like projections of collagen running through the tendon that, to those that are, I guess, uninitiated to the magic viewing crystals of ultrasound, that will look like a rotator cuff tear, but really in the subscapularis itself, that's fairly normal. So you can see these arrows pointing to these hyperechoic bundles of collagen running through the subscapularis. So don't get fooled into thinking you've got a subscapularis tear when you're scanning that cross sectional. That's what the subscapularis is supposed to look like. So word to the wise. Now let's click here. So this is kind of that dynamic scan subcoracoid impingement there. So you can see the subscapularis tendon here scanning back and forth over the coracoid process, and you can see that mechanical, they call it mechanical attrition or bursal bunching there of that subscapularis tendon up against the coracoid process. So that's a really quick dynamic scan. Basically, all the examiner is doing is moving that upper extremity in and out, and you can see whether or not you have subcoracoid impingement, or you can also just dynamically evaluate that tendon. Go next there. Yep. There we go. Okay. Infraspinatus. A lot of times you'll find modified CRAS is going to be a little bit better for this one as well. You can see you're going to be scanning a little further posterior, still aiming to get under that acromion for optimal visualization, right? So that modified CRAS position is usually where I'll scan this one as well. And a lot of times there's not a clear line of demarcation where you're going to see that supraspinatus directly turn into the infraspinatus. The supraspinatus is going to insert onto the anterior facet of the greater tuberosity, where the infraspinatus is on that middle facet. So you can kind of scan that backwards, and as you see that bony anatomy, your bony home base kind of transform, and you get a little further posterior, you'll know that you're into the infraspinatus. But that confluence area between the supraspinatus and infraspinatus is a common place to see some pathology and see rotator cuff tears or tendinopathy. So this is, I guess I just kind of touched on this, right? You've got the infraspinatus more posteriorly, the supraspinatus here on the superior facet and the middle facet, with your teres kind of coming down in here a little more on the inferior facet. But remember, if you're looking for a clear line of demarcation, like some sort of septum or something that way between the supraspinatus and infraspinatus, you're not going to see it. You're basically going to scan, from anterior to posterior. And once you see that middle facet kind of start to drop off, you'll see that you're mostly in that infraspinatus. and then the teres minor attaching onto the inferior facet of the greater tuberosity with some pictures here. Yeah. So you're basically, if you're scanning in that modified CRAS position from superior to inferior, you're going to come down across that infraspinatus and get down into the more muscular appearing teres minor. I feel like that infraspinatus is going to have that almost shiny hyperechoic appearance of a tendon, and the teres minor seems to be a little more muscular. So as you're dropping inferiorly along the posterior aspect of that shoulder, you'll still see that deltoid over the top with the teres minor behind. And then you'll see it coming in axis here, attaching onto the humeral head, with the posterior aspect of the glenoid and the glenoid labrum on the posterior aspect of the shoulder here. So it's something to keep in mind that as you kind of scan posteriorly there, the demarcation line between the infraspinatus and the teres um, is a little clearer, but you're going to see it appear to be a little more muscular. Um, so oh, it looks like I skipped something there. Sorry about that mistake there. Let's look at a couple of rotator cuff scans here with some actual pathology, right? So this is a tear in the supraspinatus. The patient in question was scanned in the modified CRAS position, right? So if we review basic anatomy here, we've got our bony home base here on the greater tuberosity with the tendon running here, the bursa up over the top, and the deltoid here. So things to notice. Um, you follow these fibers and kind of the congruous fibers of the tendon through, and you see a very clear hypoechoic or anechoic stripe within the tendon itself. And then underneath that, you'll have a humeral head defect, both of which are fairly pathognomonic for a rotator cuff tear. You may see some heterotopic ossification, whether it's kind of calcific tendinopathy with a hyperechoic deposit within the tendon itself, or kind of that scattered starry night sort of calcification that comes with a chronic tendinopathy within the rotator cuff. Another clue to a rotator cuff tear can be, you see that normal, convex crow's beak. You see as we get through here, the tendon kind of flattens out on top. If you notice that there's loss of tension, loss of fiber integrity, and you see a flat portion in the tendon, that probably warrants a little bit more of a scan to see what else is going on. Um, so touch and base just here on these humeral head defects as well. That's something they can either be acute and traumatic if there's an athlete or somebody that falls and suffers an acute traumatic rotator cuff tear versus more of a chronic erosive pathology, where there's chronic rotator cuff tendinopathy, and because of that chronic inflammation, you have an erosive humeral head defect. But once you see kind of smooth bony cortex, and then you look and you start to see melon balls taken out of the cortex, that's when you need to start worrying about more significant pathology. This is kind of that heterotopic ossification we were talking about here. It can be small and streaky or even more scattered like this, or this here. Again, understanding the scanning context, you may think, oh, we've just got an abnormal ridge in the greater tuberosity there, when really this is heterotopic ossification, and deep to it, you've got acoustic shadowing because the edge of this calcium is so firm and solid that it's reflecting those sound waves. So there's not really a void underneath it per se, but the sound waves can't penetrate down to that level because of the firmness of the calcium. Um, and so making sure that you're kind of waggling back and forth and giving the sound waves a chance to penetrate through, if possible, as well as further characterize whatever lesion you're looking at to see, is it actually what I'm seeing, or am I just seeing some anisotropy where the sound waves aren't lining up with the tissue in question so that you're able to characterize it better? Um, this is a good visualization of that biceps tendonitis that we were talking about. Here's our short axis scan within the within the bicipital groove. You can see the hyperechoic tendon with the anechoic fluid surrounding it within the sheath. And then the same view beneath with the tendon and long axis here, and the tenosynovitis of that biceps tendon creating a anechoic or hypoechoic fluid collection around it. You may see kind of some fusiform thickening where the tendon kind of gets swollen and thickened and angry as it passes through that bicipital groove as well, maybe kind of a traction phenomenon there. And that's something that you can comment on as you scan as well. But the easiest place, in my opinion, to start with this one is just looking for that peritendinous fluid within the bicipital groove. Um, Last spot I wanted to kind of touch on within the shoulder is this AC joint. You'll see AC joint pathology with AC joint sprains or chronic osteoarthritis. And looking up here, you can see the acromion here on the left, with the clavicle on the right, and then the joint itself here with a little bit of intra-articular effusion and osteophytes with maybe some age-indeterminate avulsive injuries or degenerative change from injury or degeneration of the acromioclavicular ligaments. You can also scan the coracoclavicular ligaments, but getting a handle on scanning of the AC joint with the acromioclavicular ligaments is probably a better place to start as a beginner. So some pathology that you can see here. I mean, this is a whopper of a cyst coming off the superior portion of the acromioclavicular joint here. The probe is placed in axis with the clavicle, so that you can kind of see this joint in long axis, but seen a couple of these where you get more of the moderate to severe osteoarthritis where you kind of basically get a ganglion cyst arising off of that joint. Um, you can also see this distal clavicular osteolysis once you get into the more chronic form of irritation within the AC joint, where you'll see really irregular edges on both the acromial and the clavicular side of the joint with an effusion. And then once you put on color Doppler on your machine, you can kind of see that pulsing hyperemia that will indicate that there's something more going on there. So that's the shoulder. That's one of the more common scans that I do. I find that I'm able to detect quite a bit of rotator cuff pathology and demonstrate in person and dynamically with my patients what's going on, and they like to see that, and it gives me a lot of diagnostic insight before I send them to physical therapy or do some sort of needle-based procedure or something along those lines. So very insightful. For our knee ultrasound today, the big anatomic landmarks that we're going to touch on, we got the patellar tendon, quadriceps tendon, the collateral ligaments, IT band, and the popliteal fossa, kind of painting with broad strokes there. There's going to be a lot of nuanced structures that as you get more advanced that you'll be able to learn about and learn how to detect. But as you're beginning, just basically understanding what should I look for in the anterior aspect, medial, lateral, and posterior aspect is going to be helpful. So patellar tendon, this is a really, really common scan. When you get it in longitudinal axis here, you can see on the left side of the screen the origin of the patellar tendon on the distal pole of the patella as it courses across, and then we get cut off right before it attaches onto the tibial tuberosity there with Hoffa's fat pad deep to it. You'll see this fibrillar tendinous structure that should be fairly uniform in length along its anatomic course, and you should basically see taut, intact, excuse me, typo there, intact fibers from origin to insertion without any thickening or evidence of tearing or anything like that. In short axis, the tendon to me always looks a little flatter than I imagine it in my mind. You can see these white arrowheads here indicating where that patellar tendon is with the fat pad deep to it. But you're going to see kind of more of this flattened structure than I think I have in my mind. In my mind, it's kind of a densely packed circle, but in real life, that's not really how it goes. So I feel like this short axis view is better to assess for some of those tendinopathic changes where you see the hypoechogenic focus, usually in my experience, kind of on the deep aspect of the tendon. But you can also examine the proximal and distal bony attachments to evaluate for potential avulsion or evaluate the physes for asymmetric widening or something like that. Uh, Now, moving a little more proximal to the quadriceps tendon, this scan is going to be fairly similar to the patellar tendon, where you'll be able to see it on the proximal pole of the patella. The tendon itself is going to be um, a little thicker and broader and flatter than the patellar tendon as a quadriceps course down and form that myotendinous junction into the quadriceps tendon. But you can see that coursing off, and you're going to be looking for the same thing with taut, intact fibers going down and attaching directly onto the proximal pole of the patella. In this view, you can see the joint space kind of running right down through here where this white arrow appears. And you can evaluate for a suprapatellar effusion in that area, either for diagnostic or procedural purposes. So in short axis here, again, that tendon always appears to be a little flatter than I anticipate. And directly deep to that, you'll have the suprapatellar fat pad, and the space in between is going to be that joint space where you can evaluate for effusion. And we've got some pictures of that. But that short axis view is particularly good when you are evaluating to potentially aspirate a knee effusion, that suprapatellar approach. coming onto the lateral aspect of the of that suprapatellar pouch can make it very accessible with ultrasound guidance. So here's a picture of the effusion. This is with the probe in long axis to the quadriceps tendon above, with the patella right here, and you can see that suprapatellar pouch basically kind of um, collecting all of that effusion, where you'll see that anechoic fluid collection within the pouch, and that's a really accessible place to try and alleviate somebody's symptoms from a swollen knee. As you look at the collateral ligaments, both the MCL and the LCL, I find myself scanning a lot more MCL injuries just because they're more common. Though LCL certainly is not out of the question and is fairly similar in technique to scanning the MCL. Um, so, you'll scan starting with your bony landmark. I'll usually start looking basically for this view right here with the femur on the more proximal side of the scan and the tibia distal with the meniscus, this triangular shaped portion here in the middle, and then the fibers of the MCL running up over the top. You'll usually see femoral sided injuries more commonly than tibial sided injuries, and you'll see kind of disorganization of the fibers up a little more proximal on the tibial, or excuse me, on the femoral attachment. And in grade 3 injuries, you can find that site where it's kind of fully torn through. Um, you guys are probably fairly comfortable with that valgus stress test that you'll do on physical exam. You can do an ultrasound guided or ultrasound assisted valgus stress test as well to kind of see what happens with the fibers that MCL as you evaluate it. MRI in general is going to be a lot better for evaluating the meniscus, but evaluating for a perimeniscal cyst in this area or perimeniscal inflammation, or you can even see as you scan back and forth and get a handle on what's going on, you can see in that meniscus maybe there's a cleft in the periphery of that meniscus or a hypoechoic line running longitudinally that may indicate a meniscus tear and kind of help clue you in on what's going on with your patient. So I certainly wouldn't lean primarily on on ultrasound to fully evaluate a meniscus tear, but it can be helpful in initial evaluation as you're seeing patients in clinic. IT band, as you go over to the lateral side, I included this over the LCL scan just because I find it's a lot higher yield in general than the LCL scan. You'll see a lot of IT band friction syndrome in athletes, particularly in runners, and they'll present with that lateral knee pain over the distal femoral condyle or even extending down distally, onto the insertion of the IT band on a Gertie's tubercle. So here in this picture, you can see the probe oriented in axis to the IT band as it comes down across the knee joint here and inserts onto Gertie's tubercle. For academic purposes, you could scan it more proximally up to its origin off the tensor fascia lata and the gluteus maximus. I find that rarely am I doing that scan just to scan down distally into the knee. If you're more concerned about trochanteric pathology, which we'll touch on, that's something you can do. But really, the distal third of the IT band tends to be where you'll see it when it comes to knee pathology. And you can see kind of a pathologic slide here with the IT band coming over the top, and then a significant case of IT band bursitis with the friction syndrome overlying the distal femur. I'll admit that one is a little more severe, a little easier to see than most of the cases I see. But it's a good diagnostic scan that you can kind of have in your tool belt to help with lateral knee pain in runners or other athletes that get it, but most commonly in runners. So you can see that just re-demonstrated here, just that friction with the IT band going down over the top. But you can also evaluate as to whether there's IT band friction versus a lateral meniscus tear. Um, Last little bit on the knee here. This popliteal fossa is also going to be a very high yield scan for you guys. Sports medicine, a lot of it is non-operative arthritis care and tendinopathy care. And in the case of knee arthritis, a Baker's cyst is very, very common, right? It's just a manifestation of an intra-articular effusion kind of pushing out the back of the knee and causing usually a posteromedial swelling that you can evaluate. And we'll look at a couple of pictures of that. But you can also do a dynamic ultrasound for evaluation of popliteal artery entrapment syndrome. That one is probably beyond the scope of like a beginner's lecture, but I also just kind of wanted to show other things that you can scan for here in the posterior aspect of the knee. So here's a good picture of the popliteal aspect or the popliteal fossa with a Baker's cyst, you can see this anechoic fluid collection. And as you scan dynamically, you can usually find that little stalk that goes down and communicates in the posterior aspect of the knee. And the classic place to look for it is between the head of the medial gastrocnemius coursing up over the posterior medial aspect of the knee, and then the semimembranosus coming down from above the knee joint. Kind of at the confluence of those two structures is usually where you'll find a Baker's cyst, though it's not impossible for them to look to be a little more lateral. And that's usually when you're going to start getting a little more compression or involvement of the popliteal neurovascular bundle. And that's when they can get a little bit harder to deal with. They're a lot more accessible from a procedural standpoint on that posteromedial aspect. And ultrasound can kind of help you decide, is this truly a Baker's cyst or does it communicate with the vasculature? Is it a more rare manifestation, but is it a popliteal artery aneurysm or something along those lines? So that's really where, outside of a procedural standpoint, from a diagnostic standpoint, that ultrasound can be pretty useful. Um, Popliteal artery entrapment, fairly uncommon. It's something to keep in the back of your mind, but just wanted to share this as kind of one of those nuggets that you can use for ultrasound in the future as you're evaluating patients on your own as residents and fellows and things. So popliteal artery entrapment is a exertional leg pain in the posterior compartment of the lower leg. This caused by dynamic occlusion of the popliteal artery or other surrounding vascular structures. But you can see here on the power Doppler in this patient a patent and pulsatile popliteal artery with the foot kind of in a neutral position, which is where you want to start evaluating patients their popliteal fossa is kind of that foot in neutral. So you're not compressing any structures, and that goes for both a Baker's cyst as well as a popliteal artery. But you get that Doppler on the spot, you make sure you've got a patent and pulsatile artery. And then this patient, as I had them dorsiflex, you can see there's a little less flow going through that spot as compared to before, right? As we compare those back and forth. But then the real winner on this scan came through with plantar flexion, and there was just a complete occlusion of flow of that popliteal artery. So that's something that can be really beneficial as well, or kind of more of these dynamic scans with just this um, as an example. Popliteal artery entrapment syndrome is kind of a boondoggle and is going to be a presentation unto itself. So I won't get more into the details on that, but just another case where dynamic ultrasound can be really beneficial. Hip, I find scanning hips and treating hip pain with ultrasound guidance is one of my favorite things to do. As we look, the one of the big areas we're going to be talking about is trochanteric pain with the attachment of the gluteus medius more posteriorly and the gluteus minimus anteriorly on those facets of the greater trochanter. Um, with the IT band going over the top as well as intra-articular drivers of symptoms and the IT band, or excuse me, and the iliopsoas that will come over the anterior aspect of the hip. But then posterior hip pain is one of my favorite things to treat because once you get the gluteus maximus is just kind of the muscle that's never really the problem, but just tends to be in the way. You can dive into this posterior hip pain, with the deep external rotators of the hip, piriformis, the gemelli, the obturator internus, and the quadratus femoris. That's probably beyond the scope of what we're going to talk about today, but just this is stuff that I'm about 5 years out of fellowship and stuff that I'm still continuing to learn today. That I was kind of equipped with the tools to continue learning in fellowship. So learning the basics today and then expanding on to the more advanced stuff as you gain more experience is going to be really important. So we're going to focus mostly on trochanteric stuff today, and intra-articular and anterior hip stuff. But this posterior hip is kind of more of a nuanced conversation that can bring patients a lot of benefit if you know what you're doing and know what you're looking at. So looking over the anterior portion of the hip at the femoroacetabular joint, at the hip joint itself, again, thinking about the context and the anatomy of the patient, you're going to follow that femoral shaft up in a direct line, but then that femoral neck kind of takes roughly a 45-degree jog before you get into the femoral head and the acetabulum. So looking here, you're going to see that probe oriented obliquely over that femoral neck. You're not just going to be able to follow it directly up into the hip joint, into the hip joint, but you'll see the humor, or excuse me, I keep saying humerus, not the humerus. You're going to see the acetabulum here. Goodness gracious, talking about basic anatomy, right? You're going to see the femoral head here with the joint capsule going over the top, and then the iliopsoas tendon directly over the top as well. Um, Down here, you're going to see the start of that acetabulum with the femoral head, very similar to the glenohumeral joint in the shoulder. And you can evaluate for a hip joint effusion or an iliopsoas bursitis and things like that. This iliopsoas tendon is something that you're going to look at quite a bit with anterior hip pain as well. This is going to have the probe oriented in short axis to the joint and to the muscle itself, so you can see the bulk of the iliopsoas muscle directly overlying the hip joint itself, with the acetabulum here and the head of the femur here. So there's a reason that this iliopsoas tendonitis or iliopsoas bursitis can mimic intra-articular hip pain, whether it's from hip impingement or hip arthritis or something that way. This hyperechoic structure right here is the start of the formation of that iliopsoas tendon, where it basically sits right on top of that hip joint, and so it can be really hard to distinguish between which structure is causing what symptoms. But the bursa kind of sits deep to that between the femoral head and the body of the iliopsoas tendon. So kind of right here, deep underneath that tendon. Excuse me, I keep clicking there. That's where you're gonna see that tendon and that bursitis. So here's kind of a good demonstration of it, where you can see the bursa coming in deep in short axis here with the iliopsoas sitting on top, and then kind of a more of a long axis scan here with the shaft of the femur coming down this way, and that iliopsoas bursitis right here with the tendon coming down over the top with that fluid collection. You can see this in an active population, but I see it not infrequently in patients that just got a hip replacement and may continue to have that anterior hip pain, and they can have that friction syndrome with the iliopsoas tendon over the top, and that's a fairly easy scan, just to scan over the top of that hip joint to see if there is a fluid collection exterior to the hip joint, or if there's some sort of intra-articular fluid collection that needs to be assessed further. So being able to differentiate between those two using an in-office ultrasound can be really, really beneficial. Looking at the lateral hip, this is something that you're going to spend a lot of time scanning as well. That I spend, when it comes to hips, I spend a lot more time scanning the lateral and the posterior hip than I do the anterior hip. But understanding again dynamically and in context what the anatomy is doing, um, you can look here over on C that the gluteus minimus is going to kind of come in and attach on the anterior facet of the greater trochanter, where the gluteus medius is kind of supra-posterior there. And that's, as you're scanning, understanding which tendon you're looking at and what anatomic course you're following as you look for pathology is going to be really important. And just remember, the gluteus maximus just kind of always in the way. So you don't need to spend a lot of time evaluating that one for our purposes today. So lateral hip here, again, finding that bony landmark and kind of finding the crest of this greater trochanter is going to be important. Um, and as you come off, I feel like both of these actually, you can see anterior, posterior, anterior, posterior. So you see the gluteus minimus coming off the anterior aspect of the greater trochanter, and the gluteus medius coming off the posterior aspect of the greater trochanter. And very similar to a rotator cuff ultrasound, you're going to be looking for bursitis, trochanteric bursitis, between the bursa and the gluteus maximus sitting above it. You can also evaluate for cortical erosions or heterotopic ossification, very similar to a rotator cuff. Even though the hip is not as dynamic as the shoulder, I feel like this scan of the trochanter is very similar to a rotator cuff scan, where you're going to be looking for a lot of the same things. So you can evaluate those tendon attachments onto the greater trochanter. You can evaluate for bursitis, and then you can also evaluate the cortical surface of the greater trochanter that can give you clues as far as pathology that you may or may not be seeing. Um, Trochanteric bursitis here. I'm on a crusade against, I guess, just labeling lateral hip pain trochanteric bursitis, because the bursitis isn't the problem. It's very rarely just an isolated finding. The cases I've seen that I think are truly isolated would kind of be traumatic, where somebody fell directly onto the lateral aspect of their hip. But if you see bursitis you need to keep looking and ask yourself why. And that's true in the shoulder, that's true in the hip, that's true just about anywhere. Bursitis is a symptom, it's not a cause, and you need to keep looking. So, usually in the trochanteric bursae, if you see bursitis, you need to keep looking for a gluteal tendon tear or a gluteal tendinopathy because there's something causing that bursitis. And finding a bursitis and calling it a good day's work after that probably isn't as thorough as you want to be. You want to keep looking for that cause. Um, so, talking about the posterior hip here, we're not going to get into the deep external rotators quite as much, but we are going to talk, about hamstring scan. I do feel like that one is a little easier to start with, and something that is going to be fairly commonly evaluated in a sports clinic as well with young, healthy athletes, as well as older folks with degenerative tendinopathy, that might be more kind of a chronic issue. So, looking at the posterior hip here, you have the patient in the prone position and finding again that bony home base right here, that hyperechoic reflected surface of the ischial tuberosity, um, with the conjoint tendon sitting over here with the arrowheads, well, I guess with the arrows here, and then the semimembranosus is going to be deep and a little further lateral here, and then you can kind of see the sciatic nerve that's better appreciated kind of with a dynamic scan once you get the anatomy down. Is something that you can look to as well. But evaluating the ischial bursa, which is going to sit right up over the top here, as well as the conjoint tendon and the semimembranosus tendons directly as they attach onto the ischial tuberosity is going to be an important skill to have. And then again, you're looking for the same things. You're looking for abnormal fluid collections, fiber incongruity, and cortical erosions or avulsions off the ischial tuberosity. Um, as you scan distally down the posterior aspect of that hip, those of you guys that have done like echoes and stuff like that, they talk about the Mercedes-Benz sign with the valves in the heart. There's also a Mercedes-Benz sign in the hamstring that's going to be an important area for you to be able to kind of evaluate, right? So looking here, you see this illustration on the right with the mirroring ultrasound image on the left, so you can kind of line them up. So you've got the biceps femoris right here with the common tendon coming down and splitting the two. And that's where you get this Mercedes-Benz sign. Deep to all of this, you have the adductor magnus, and then lateral, or excuse me, medial to it, you'll have the semitendinosus. So kind of scanning down to where you see that three pointed with the central tendon, biceps tendon laterally, semitendinosus medially, and then kind of at the center of that Mercedes-Benz sign is the sciatic nerve, right? So as you get down into that area, that's going to be a pretty important area for you to be able to scan and identify ultrasonographically, if you're looking at an athlete with hamstring pull, hamstring tear, something like that. And then just remember that adductor magnus kind of lies deep to it all. So here's a pretty good image of a hamstring strain kind of at this junction of the semitendinosus and the biceps femoris long head. You'll see loss of kind of that muscular fibrillar architecture, superficial to the sciatic nerve here. You can see this hypoechogenic fluid focus through here where you lose the integrity of those fibers. It can be indicative of a hamstring tear. And there may or may not be a big anechoic fluid collection indicative of a hamstring, or excuse me, a hematoma collection that needs to be aspirated. Um, so want to wrap up here, and just remind you, ultrasound is a language, guys. Going through and seeing this stuff, to my eyes, you go back through all of these slides here. To my eyes, this stuff makes a lot of sense because I've looked at thousands of these images, and I have partners and mentors and people that have looked at millions of these images and are far better equipped than myself to be able to um, talk about these things, right? Seek out hands-on experience any chance you get, because until you have a probe in your hand, you can look at all of the ultrasound pictures you want. If you can't put those pictures in context of where your hands are and where that physically lies within a patient, you're going to be left behind. Reps are what matter. I remember in fellowship, I started out and thought I had done a lot of work as a family medicine resident on ultrasound, and I feel like I was decent. But I got into fellowship, and that first month of fellowship smacked me in the mouth. It was humbling, and I realized how deficient I was and how I wasn't as good as I needed to be, particularly from a procedural standpoint, right? So rather than just waiting for my reps to come to me. I Googled how to make kind of a home ultrasound model, and I found it. I made a big bowl of Jello, and I think it was psyllium that you put in there so that you can't directly see what's going on. And then I put blueberries all over in the Jello, kind of at different levels. And when I would get home from work in fellowship, I'd get out my ultrasound bowl and I'd take my butterfly portable ultrasound scanner, and I'd bring a spinal needle home from clinic, and I would practice hitting those blueberries over and over again from all angles as I was, kind of winding down with my wife at night, watching TV, doing whatever we were doing. Um, and that helped me pick up those extra hundreds to thousands of reps that I needed so that I could improve, and not flunk out of fellowship, quite frankly. And the other thing is to learn from anyone, right? Like you guys are on this because you at least have some passing interest in sports medicine, whether or not you're going to look to pursue a fellowship. Um, but I've got ultrasound techs in my clinic here that do DVT scans and get all sorts of scans outside of the musculoskeletal realm from other physicians. And we've developed a really good collaborative partnership where if they get something they don't know what they're looking at, they'll call me down and have me come and look, and I can hopefully lend some insight. And they've taught me a lot of things about scanning that maybe falls outside of my wheelhouse. If you're on OB, get your hands on a probe and learn how to do the biparietal diameters and head circumference and everything else. I did a lot of that in residency, and that just helped me develop a lot of comfort with an ultrasound probe in my hand. I won't admit to proficiency in those areas, but learn from anybody. Anybody that knows anything about ultrasound, ask them what they see, how they do, what their technique is, what the common pitfalls are. Don't be too prideful to ask for help, right? So just remember the little Duolingo owl. Those of you guys that do Duolingo and get those annoying little pop-ups every day, like, did you practice? Did you do it? It's the same thing with ultrasound. Did you practice today? Did you learn something? So, with that, those are kind of the basics I wanted to talk about today. Does anybody have any questions? I've included my email there, so if anything comes up, I'm happy to have you reach out to me kind of offline or anything, but happy to field any questions at this point.
Yeah, Dr. Pickett, I had one question. So do you have any recommendations for the best like open access resources or like online modules for students or residents who are developing ultrasound competency or like starting to build that foundation?
Excellent question. Yes. From an anatomic standpoint, Jonathan Finoff did a series of videos on the AMSSM website, the American Medical Society for Sports Medicine. And he is one of the godfathers of musculoskeletal ultrasound right now. He knows his stuff beyond anything I could ever hope to achieve. And he just made basically a body region by body region YouTube library of stuff that you have to be a member of AMSSM to join. I think that would be well worth your time to go through and start seeing. And he shows you probe position, where to scan, what it should look like, and gives you the basics of every area that can be really, really beneficial. Included in my sources here, I've included a couple of articles from the AJR, from the American Journal of Radiology. Awesome resource. If you just Google AJR lateral hip or AJR rotator cuff tear or AJR this, AJR that, they're going to have picture after picture after picture after picture, along with pro position of stuff that you like, that Mercedes-Benz hamstring slide that I put in there. I'm almost positive that came from AJR, and that stuff is easily Googleable, and they're open access. Um, and then not necessarily open access, but a lot of the pictures I took for today's presentation is a book that I'll still refer to from time to time. This Fundamentals of Musculoskeletal Ultrasound by Jacobson is awesome. Gives a lot of good pictures, a lot of good orientation on things that you should be looking for, and gives really good explanations that way, so it can give you some context as well. And they get into more of the advanced scans and stuff that way too. So AJR and Jonathan Finoff, I think, would be my two top answers on that. Those Jonathan Finoff videos on the AMSSM website.
Awesome. Thank you. And we also had a question in the chat. How do you make the Jello concoction for practice? You said psyllium.
Yeah, there was. God, I'm trying to remember. Honestly, Google it. But basically, you get a big bowl and you fill it with as much Jello as you can, and then there's a certain, like, you just basically add in the psyllium um, so that it kind of reflects a little bit more and it just makes it opaque so you can't see through with the naked eye. And then you just put when it kind of starts to thicken up, but it hasn't quite gotten to that texture. I did blueberries. I know a lot of people have used a lot of other stuff, hard candies or whatever that you can just kind of put throughout the mold as it's hardening up, and then just practice hitting it with an ultrasound. I know there are more formal models and formal ways that you can do that, but that was pretty cheap and easy and accessible when I was in fellowship. So I'd do that, and I would find that the mold would tend to last maybe a week, and I'd have to make another one. But once I got hundreds to thousands of reps of hitting it in every plane and axis that I could, I found that helped me be a lot better procedurally with the ultrasound.
Awesome. And we had another question. Are there any good ultrasound guided books that you would recommend?
Yes. God, let me pull up my phone here. There's kind of the basic standard one. Just pulling up my phone here because I had it on. Well, I still have it on my phone. I just don't need to refer to it quite as often. But I would have it on my phone in fellowship so that if I ever got asked to do an injection that I wasn't quite sure on, I could review it real quick. It's entitled Atlas of Ultrasound Guided Musculoskeletal Injections. The authors on that are Malanga and Matir. Um, and then Ken Mottner also is an author on that one. So that's Atlas of Ultrasound Guided Musculoskeletal Injections by Malonga and Mottner and Matir. That one I think is probably the best one to start out with. It just gives a really brief rundown on pertinent anatomy, ways to set people up, set the patient up, needle approach, needle size, and things like that. And for the probably the 85 to 90% of procedures that you're going to be doing most frequently, I think that book is a really, really good resource as you're learning.
Alrighty. Um, yeah, before we conclude tonight's webinar, I just want to express our gratitude to Dr. Pickett for taking his time out of his evening to share his expertise on musculoskeletal ultrasound and sharing all his advice with the students and residents who attended tonight. Your presentation was really awesome and insightful. And also thank you for everyone who came out to tonight's webinar. Before we fully conclude, I just wanted to encourage everyone to join us for Thursday's webinar on November 20th at 8 o'clock Eastern Standard Time for an adaptive sports lecture featuring four Paralympic team physicians, Dr. Mike Yulin on USA Paralympic sled hockey, Dr. Kyle Nagel on USA Paralympic Nordic ski team, Dr. Stephanie Toe on USA Paralympic swimming, and Dr. Irfan Asif on USA Paralympic wheelchair rugby. They'll be discussing cardiac concerns for Paralympic athletes. And if all medical students and residents can vote for the medical student interest group and the resident interest group elections that have just been sent out, that would be great. That will be available until Tuesday, December 2nd. So it has been my pleasure serving as today's moderator. That concludes today's webinar.